NEET, INICET is not for us. You know, basically what I have seen in the previous question papers of like INICET pattern is that they try to just play with your mind. Okay, they just try to frame a question which is very lengthy, like some 7 to 8 sentences, and the time you read the sentence, you'll get panicked. Oh my god, that's all. I don't know the answer. Or it will be like the choices. The choices will be made in a way that they are like twin brothers. Like you see one choice and another choice, you don't find any difference. You will be like clueless. Okay, this is not going to happen. So basically what happens is that you just be prepared for that. Okay, mentally you should be like prepared for such type of questions. Second thing is that they frame the questions in a way that the students are very sure about the concepts. Okay. Now, for example, like I am setting a question paper. Okay, I set a question paper and you are there and you are asking me like, sir, I find a fault in your question. I find very bad, right? I'm just 10 years into psychiatry. But the professors who are setting the question paper are like too old and too experienced. So they make sure that the way they frame the question, there'll be classical catchy lines, which is very classical about any disorder. Okay, so when you have the concepts very strong, answering the question is not going to be difficult. Okay, so with this small introduction, we'll step in. You're all ready? You're all ready, friends? Yes? Yes? Anybody in the live chat? Yes? You are good to go? Can we start? Yes. Now, first and foremost, I'll be asking about the first question, which was asked in INICET November 2022. What is this table? Okay, usually what happens is that this like these table are mainly to just make you like feel like you're not going to answer this question, or this is the most difficult question on earth, but it's a bit easy question. Okay, now what are the choices that is given? Kleptomania, pyromania, dipsomania, and nymphomania. Okay, so what do you think is the what do you feel about what do you explain about each of this? Good. Thank you, Rohit and Satya. Now, what happens is that I'll first finish off the discussion, and slow and slowly we'll have, if time permits, we'll go for a discussion. Now, rather than just getting pressurized on seeing this, just have an idea of what is everything. Okay. Just you should know, what do you know about kleptomania? What do you mean by kleptomania? Kleptomania is nothing but it's a type of an impulse control disorder. Yes, good. That everybody knows. Fine. Now, this kleptomania means what? It's nothing but a person has a desire or an urge to take away small things. Okay, just to be like 2 rupee things or 3 rupees, like 5 rupees. The person can very much afford, but he has the urge to take things without paying it. Okay, it's different from stealing. What is the difference between stealing and kleptomania? The difference between kleptomania and stealing is that in stealing, okay, a person steals. Okay, I go to a Kanishk jewelry and take a diamond necklace and just put it in my pant and then run away. That is stealing. Yes. What is kleptomania? Kleptomania is where a person goes to a departmental store or a fancy store. The person goes and takes some 5 rupees small, what to say, small rubber band, or a thing which is very much affordable. The person will be having some 2,000 or 3,000 in the pocket, but still the person will take things like 3 rupees, 5 rupees, 10 rupees, 15 rupees, which the person can very much afford. Okay, the difference what we say between stealing and kleptomania, that's very important to know. In kleptomania, the person has a desire to do it. Okay, the act, yes, I want to do it. The act is the goal. Yes. Whereas in stealing, why does a person steals? The object is the goal. Yes. Yes. Are you able to find a difference? Are you able to find a difference? In stealing, the person, what he takes, that is the object is a goal. Whereas in kleptomania, the act of taking, the act of taking it without paying the bill, that is a kick, that gives them a kick. Okay, that is a difference. Now, very importantly, the person when he frames a question, he will frame a question that a person takes things without paying the bill, and it is very cheap, it doesn't use it, and it is like the person is very much affordable. These are the points which tells you that this is not stealing. Yes, this is kleptomania. Now next, something is called as a pyromania. What do you mean by pyromania? Anybody? Pyromania is setting fire. Setting fire. A person sets fire. Pyro means what? Antipyretic. Fire, fever, pyro. So fever, fire. So sets fire. The person keeps on setting fire is called as pyromania. There are other types of mania which they have asked in the choice. It's nothing but nymphomania. Have you seen that choice? Nymphomania. What do you mean by nymphomania? Anybody? Anybody can tell me? Nymphomania. Nymphomania is nothing but a person. I'll just introduce you 4 terms under this sexual addiction itself. One is called as nymphomania. Another is called as satyriasis. Another is frigidity. And the other name for satyriasis is nothing but Don Juanism. Yes, yes. Now we should know what is going to happen here. In nymphomania is seen in females, and frigidity again is seen in females, and Don Juanism and satyriasis we are going to deal with males. Yes. Now going one step ahead, nymphomania in females means that the person is having increased sexual desire or addiction. Satyriasis and Don Juanism also means increased sexual desire or addiction. Whereas frigidity in females means decreased. The person has a decreased addiction. Yes, 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 you're all with me. You're all with me. Please concentrate because this is where a lot of times students tend to know the point, but because of like anxiety, they just make it wrong. You should be very clear in your mind. Nymphomania, frigidity is females. Yes. Don Juanism and satyriasis is males. That's it. Pakka. There is nothing called as like I forgot, sir. Nothing. Nymphomania, frigidity. What is it? Type. Everybody type. Nymphomania and frigidity. Seen in. Come on. Type. Let's make it like a bit interactive. Yes. Good. Now, what is this Don Juanism and satyriasis? The Don Juanism and satyriasis is nothing but where it is seen in males. It's both the same term, males, where there is increased sexual addiction or sexual drive. Yes, you're very much sure with this. Yes, good. Now, other things that you should know about is there are other types of manias. You know, mania is per se a psychiatric disorder, but there are some other types of manias, the fancy terms that they introduce, that if you have an idea, it will be very much useful. I'll just introduce the terms. One is known as oniomania. Have you heard of this? What is called oniomania? Oniomania means it's a compulsive buying. Yes, oniomania means the person goes and buys more than what it is needed. The person doesn't have a control over it. That is called as oniomania. Dipsomania. What do you mean by dipsomania? Dipsomania means compulsive drinking, okay, of alcohol. That is called as dipsomania. Yes. So I've introduced nymphomania, increased sexual addiction, females. Clear. Oniomania, compulsive buying. Clear. Dipsomania, alcohol. Yes. What is pyromania? Fire. Kleptomania, taking objects. Please don't write kleptomania is stealing. Kleptomania is different, stealing is different. Yes. We are clear with this. Now, if you want to just know 1 point extra, INICET is all about saying or knowing some points extra than others. If you want to know 1 point extra, we have something called as impulse control disorders. See, the kleptomania and pyromania is still classified under impulse group of disorders. So what you should know about these some 5 changes in impulse control disorders is one very important thing: pathological gambling. Pathological gambling, where people spend a lot of money, okay, on like they just put money too much on like the gambling thing. Now what happens is that this pathological gambling was once classified under impulse control disorders, was once classified under impulse control disorder, but now it has been classified under what is it called as addiction disorders. It is now classified under addiction disorders. Yes. Now it is classified under addiction disorders. Yes. Pathological gambling was once classified under impulse control disorder. Now it is classified under addiction disorders. This is what you know about DSM-5. In ICD-11, okay, in ICD-11, there is one point that you should know. They found that, see, what happens is, what is this pathological gambling is that you go, you spend, you put some 100 rupees, the person gets 1,000. That's, they are brilliantly designed in that way that a person gets some money. Okay, so if you put 100, you get 1,000. You will not go to home. You put 1,000, you get 10,000. You are very happy. You don't go home. 10,000, you get 1 lakh. That's all. You are like in high. Now you will not go home with 1 lakh. What you will do? Any person, what you will do? Even I am in that position, what I will do? Let me put 1 lakh so that I might get 10 lakhs. But that doesn't happen. That doesn't happen. So something like an addiction. Now ICD-11 says that there is another disorder which is something similar to this gambling, which can be also classified under addiction, and that is nothing but gaming disorder. Gaming disorder. Okay, where the people keep on playing. It's more common in adolescents and children, where they spend too much of time on gaming, like round the clock they'll be on gaming. So that is a gaming disorder. Okay, so new addition under addiction disorders. Under addiction disorders. Okay. Yes, friends. Yes, friends. I'll just go for a quick recap. That's my bad habit plus good habit. So please bear with me. Kleptomania is impulsive way to take away objects. It's not stealing. Why, sir, it's not stealing? Because stealing is your object. A diamond necklace. It's a goal. Whereas in kleptomania, the act of taking is a goal. That's it. Very clear. That should be very clear in your mind. Pyro. Setting on fire. What is this? This slide you can't make to afford to make a mistake. Nymphomania means what? Increased sexual desire in females. Frigidity, decreased sexual desire in females. That's it. Very clear. Now, what is Don Juanism and Satyriasis? It is increased sexual desire in males. Very good. Now, what is oniomania? Compulsive buying. What is dipsomania? Alcohol. Now, if they are interested to know that whether you have some more concepts in your hand, they will ask you, pathological gambling was once classified in a dash, but now classified under addiction disorders, impulse control disorders. What is the new addition of ICD-11? ICD-11 is another diagnostic classification which is not present in DSM-5. Okay, you should know about this word, gaming disorder. You know, right? In COVID, most of you would have done that when you're like in the COVID ward and post quarantine and all that. We'll be all involved in gaming, right? So gaming disorder. Now we'll go to the next question. This is what I told you, initially, like people used to see that like all choices, if you see, like they'll be like twins. Okay, I'll just read the question. A 14-year-old girl is there, her mother is dying. Okay, she got blind suddenly, but she was not bothered about it. Which of the following statement is correct? Okay, I feel that the examiner wants to know that very evidently that you should diagnose this disorder. This does nothing but what disorder? Any idea? Very, very, very obvious. What disorder? Yes, the disorder is nothing but, anybody wants to type in the chat? Yes, very good. The disorder is nothing but the person has conversion disorder. Okay, now they are still giving multiple choices. What are the multiple choices? Adult male, female has equal incidence. Adult males have high incidence. Children equal incidence. Children occurs in females more. Okay, so it's a bit confusing. Okay, now the answer is very, very, very simple. It occurs in females. Okay, for that you should know some idea about what is happening in conversion disorder. Okay, what are the terms that you should know in conversion disorders? That first and the foremost, you should know conversion disorder is also known as functional neurological disorder. It's called as a functional neurological disorder. That's the first thing that you should know. Second thing that you should know is, okay, there is something. What is this actually? What is this conversion disorder? Is that a person is here. Now, what happened is that this person, please concentrate. I have a stress. Okay, I have a stress. I'm not able to handle that stress. Now, as I'm not able to handle the stress, I will present with a sudden neurological symptom. Okay, one case which I've been saying in classes for years, because it was the first case by which conversion disorder was diagnosed by Sigmund Freud. A person has a trauma or a stress. Now, suddenly what happens is that she presents with a symptom, that is that she is not able to walk. Okay, paralysis. She's not able to walk. Now, why is this happening? It's because of first one very important point, that is because of repression. What do you mean by this repression? Repression is nothing but a person is not able to handle the stress. A person is not able to handle the stress. Yes, I got it. But he puts it into the unconscious. It's like a ocean. Okay, mind is like an ocean. Okay, now he puts it to the unconscious. That is called as repression. Very simple. You tuck it into the unconscious. That is repression. Now, what happens is that once it is tucked into the unconscious, it's not going to be happily sitting down there. Okay, what it will do is it will go, and what it will do is it will have something called as symbolization. Symbolization. What do you mean by this, sir? Symbolization means it will come out as the symptom, right? Some motor symptom, paralysis, something. Now, the presenting symptom, a person comes with some motor symptom. Okay, this will have some connection to his unconscious, desires or a drive or impulse. Okay, that's what you should know. See, I have a symptom. Why some people present with paralysis? Why some people present with sensory symptoms? There are people who come and say that, sir, I'm not able to see, blindness, deafness, aphonia, okay, dysarthria. Why is it? Because that's what makes psychiatry very interesting. You go and understand what has happened in the history. 10 to 2 years before this happened, this particular thing happened, and because of which I felt very guilty, and because of the stress this happened. It's unfolding of the story, and I think that's what makes psychiatry interesting, and that is called as symbolization. Now I have a symptom. Why this particular symptom occurred? When you are able to find a track, that is called as symbolization. Simple. Now we have something called as modeling. This is most commonly seen in children. Okay. Now what happens is that there are people who come to my clinic who comes with like seizures. I ask them like where did they see the seizures? Now if I ask them, is there any family member who have the similar symptoms? Yes, there is a family member. So that is nothing but copycat. Okay. Now you're copying symptoms. You're just Control C, Control V, copying the symptom of the family member and presenting in your symptom. That is called as modeling. You know models, right? Modeling. Yes, very good. Next, we have something called as very important point, labelly indifference. So what do you mean by this, sir? It's very important. This is what is given in your question also. It says that the person is not. Imagine that tomorrow you're not able to walk, you're not able to talk, you're not able to see anything. How will be your anxiety level? You'll be like anxious to the core, right? But this person doesn't have a concern. That is called as labelly indifference. The textbook definition says that apparent inconcern towards one's own illness is called as labelly indifference. And I'll just introduce you to the another point, astasia abdasia. What do you mean by this? It's a type of a gait, okay, which is seen in conversion disorder, where the person will walk as if he's having multiple neurological symptoms. He's about to fall, but he will not fall. That is called as astasia abdasia, gait seen in conversion disorder. What is the other name for conversion disorder? Functional neurological disorder. Sir, is there any named sign, sir? Yes, there is a sign called as Hoover's sign. I'll finish it here itself. Hoover's sign. There is a sign called as Hoover's sign. Okay, where like what happens is that a person comes and says that, sir, this leg is paralyzed. Now what I'll do is I'll not give importance to this leg, okay, because the person will be concentrating on this. Okay, now I'll just check the power of this leg and I'll see the reflex and all that. I'll be concentrating on this. Now by the reflex, as I concentrate on here, by the normal reflex arc, there will be tension built in this so-called paralyzed leg, okay, by which you can find it. That is called as Hoover's sign. Okay, so Hoover's sign is the characteristic feature of what disorder? So you should be confidently saying that it is seen in conversion disorder. A small quick recap: conversion disorder is also called as functional neurological disorder. No doubt. Now what is repression? There is a stress, the person tucking into the unconscious, which will present as conversion symptoms. So repression is the main defense mechanism. What is symbolization? Sir, the presentation that I have, a paraplegia or a hemiplegia, I have some connection to my unconscious desires. And if I have a symptom which one of my family members is having it, I'm copying it. It's called as modeling. What is labelly indifference? Labelly indifference is nothing but person has apparent inconcern towards one's own illness. And astasia abdasia means it's a type of gait seen in conversion disorder, and the sign that is seen to confirm or to have an idea that this is conversion disorder is Hoover's. Yes, friends, you're all with me? Yes, good. Next we have I told you, like this is the pattern. Okay, you just be prepared. till your exam. Yes, it's going to be minimum 5 lines. Yes. A 53-year-old male who's a chronic alcoholic tried to stop using alcohol after several requests by his family members. Very good. He started feeling uneasy, and on day 3, he had clouding of consciousness, insomnia, and visual hallucinations. He was agitated and started abusing everyone around. He was shaking and sweating profusely, which is your probable diagnosis. Very good. Very good. Now, you're able to come to a point where is the diagnosis and all that. Yes, very good. They are asking about, it's a small clue. Okay, again I told you, please try to get clues from the paragraph itself. He's a chronic alcoholic, so it's not a person who's just a social drinker. He doesn't take it like once a day. Okay, so it's a chronic alcoholic. That's a point. He's stopping. Yes, very good. He's stopping alcohol on day 3. My god, my god. If you see that examiner, you should really get blessings from the person who has set this question paper, because he wants to make sure that the students get the clue, all possible clues. Day 3, he has clouding of consciousness. Consciousness is clouded. He's having insomnia. He's not sleeping. Wonderful. Visual hallucinations. Wonderful, wonderful. He was agitated and started abusing everyone around. He was shaking and sweating profusely. Wonderful. By this time, I think you will be able to get the answer. So the answer is nothing but it's a person who is in ADS. This person is having alcohol dependence. Yes, the person is in alcohol dependence. Now we have stopped alcohol. When you stop alcohol, there are various withdrawal symptoms that arise. Within 6 to 8 hours, a person will have what? Within 6 to 8 hours, the person will have what? The person will have something called as tremors. Within 12 to 18 to 24 hours, the person will have what is called as seizures, also called as rumpets, because it is called, the fit is caused by rum, we call it as rumpets. And after 72 hours, a person has what is called as DT. Concentrate. This is where our answer is. Okay, when a person prepares for a NEET exam or an INICET exam, he should have a very strong knowledge on what is DT. Okay, so the clue, if you have just read, you know only this, you do not know what is DT also, but with this, if you know this time duration, you'll be able to answer, because they have told that it's a chronic alcoholic. He stops alcohol. After stopping alcohol on day 3 is basically left what, 72 hours. So the person is having DT. Now, if you know the symptoms of DT, it makes your life more easy. Sir, what happens is that, please tell me, sir. Delirium is nothing but, the words that you should know is, it is nothing but altered sensorium. Please search for in your exam. Is there any word called as sensorium is altered? No, that's not there, sir. Clouding of consciousness. Is conscious is not clear. Okay, it is clouded. Clouding of consciousness. Very good. Very importantly, the problem with this delirium is that they have disorientation. To time, place, and person. Yes, they have disorientation to time, place, and person. And very importantly, these people will have what is called as attention problems. Okay, the cognition, the main part of the higher mental function that is affected will be attention and disorientation. Attention, disorientation, and concentration also. Good. And very importantly, most common cause for visual hallucination is. This question is like, it's like a question that is asked for a first MBBS student. Most common cause for visual hallucination is. So the examiners expect that, okay, the students will know this answer. The most common present for visual hallucination is delirium tremens. So visual hallucinations. The person present with visual hallucinations, and very specific visual hallucination that you should say in delirium is sundowning phenomenon. Where in sundowning phenomenon, the hallucinations are more predominant. Why, sir? See, normally itself, a person who's active, alert in the morning, it's fine. But when as in the darkness, you will see something. It's hazy. You feel some like what to say. You are not comfortable, like as it goes in the darkness to go from one room to other room. Now these people are disoriented, have attention concentration, so there will be worsening of symptoms in the dark. That is called a sundowning phenomenon. Some people can come and say that, sir, I had one type of hallucination called as Lilliputian hallucinations, where I see small people. Okay, Lilliputian hallucinations. Yes, When you just reread the question, it will have points of altered sensorium, clouding of consciousness. He's not oriented to time, place, and person. He's not having attention concentration. He's having visual hallucinations, sundowning phenomenon, Lilliputian hallucination, and the person will have autonomic disturbance. And very importantly, they will have what is called as tremors. Why are you saying this, sir? Because it was named delirium tremens because delirium is a per se a separate psychiatric disorder or organic disorder. You have a number of causes for delirium, but when the delirium is associated with tremors, and it is due to alcohol withdrawal, we call it as DT, delirium tremens. So if you just reread the question, you'll be able to see that this is like the examiner is really loves you to get the mark, and that's why he has set the question up like this. Yes. Very good. Now with this idea, you should know into what is the treatment for delirium. Basically, what you should know is what is the treatment for alcohol withdrawal. The treatment for alcohol withdrawal is very simple. Very simple. A person comes, he wants to stop alcohol. What is the first thing you will do? First thing you will do is detoxification. What do you mean by this? What you do is you avoid a person having withdrawal. It can be tremors, or it can be because if you stop the person, if your person stops alcohol within 6 to 8 hours, what are you going to have? He's going to have something called as tremors. Within 12 to 18 hours, he's going to have something called as fits. Within 72 hours, he's going to have something called as delirium tremens. So to avoid it, you should use a drug, and only drug that is used for detoxification is benzodiazepines. Yes. Yes, I want you to be very clear. Two questions which I'm going to follow in the following slides. You'll be seeing the question is on this benzodiazepines. Now, this benzodiazepines, there are various types of benzodiazepines. What benzodiazepine should I use, sir? What I'll do is immediately a patient gets admitted, I'll just take a blood test. If the LFT of the patient, that is AST, ALT, GGT, if it is LFT of the patient is within normal limits, I will go to choose a drug which is similar to the structure of alcohol, that is called as chlordiazepoxide. Please concentrate. Chlordiazepoxide. Sir, no, sir. I checked the LFT of the patient. The LFT is very much deranged. It is deranged. LFT is not noted. What is the drug that I should use? You should use a drug which is a short-acting drug. Okay, short-acting drug, and which is nothing but most of the choices which I have seen as this one short-acting drug, which is very common, that is lorazepam. What is this LFT deranged means? I think this they will teach you in biochemistry, medicine, and all that. I'll just say this: AST and ALT normal level. Okay, this is around, like, if the level is normal, what happens is that more than 5 times the level is called as abnormal. What we call it is anything more than 200, around 200 and more is called as deranged LFT. Yes. Yes. Now I've admitted a patient. I know that the person is having withdrawal symptoms. He's having delirium. Now, sir, do we have any scale? Do we have any scale to assess how the patient is improving? Today I have some score. It should improve. No, it should keep on improving. Otherwise, I should know that what treatment I'm giving is not right. Right? Is there any scale for specifically for delirium? I'm specifically added this point because this is something which most of them might miss. Okay. Now, what are the scales that you should know is, please concentrate. We have a scale called as SIVA-AR. Okay. And there is something called as CAM. What is the SIVA-AR? Clinical Institute of Withdrawal Assessment. Says as alcohol revised. We remember it in the name of Lord Shiva. So SIVA-AR. Okay. What is CAM? CAM is that the person is having clouding of consciousness, right? So we have something called as confusion assessment method. Yes. Basically, they want you to know these concepts before you step into your exam hall. Just brush these concepts again and again. Now I'll just go into quick recap. Now this person is having alcohol dependence. After 6 to 8 hours, what he'll have? Tremors. 12 to 18 or 24 hours, he'll have seizures or fits. After 72 hours, what he'll have? DT. What do you mean by DT, sir? DT is nothing but altered sensorium, These lines, this images should be in your memory. Altered sensorium. Search for the word altered sensorium, clouding of consciousness, disorientation, time, place, and person, attention concentration problem, and very importantly, please concentrate. The person will have sundowning phenomenon, Lilliputian hallucinations, visual hallucinations, and they will have something called as autonomic disturbance and tremors. Now, what is the treatment of delirium? You'll have benzodiazepines. If the LFT is normal, go for chlordiazepoxide. If the LFT is abnormal, you need to go for what is called as LFT is deranged, go for lorazepam. Now, what are the scales that is available? The first scale that is important is SIBA-AR. SIBA, Lord Shiva, SIBA-AR means Clinical Institute of Withdrawal of Assessment, Alcohol Revised. And what is CAM? Confusion Assessment Method. Okay, both are used in delirium. This is mainly for DT, whereas CAM can be used for any type of delirium. Yes, thank you, friends. Wow. See, I can predict what is going to happen in the future. Now read this. A patient with chronic alcohol use, around 1 bottle of whiskey daily, stopped consuming alcohol for 2 days. He was brought to the emergency on investigation. Liver function test is deranged. Which of the following should be given for detoxification? Very simple question. Very simple question. Liver function test is deranged. The person is brought to the emergency. Okay. Stopped consuming alcohol. So he's having withdrawal. So what you will choose? Lorazepam. I think I have answered the question for this. This answer is where you should search. There is nothing called as LFT. So what we are going to choose? We are going to choose a drug which is diazepam. Now what the only answer with the diazepam is having thiamine also. Why you should give thiamine? This is another point which again was the question the recent meet in March. We had a question, right? Wernicke's encephalopathy, where the person will have triad, global confusion, ophthalmology ataxia because of thiamine deficiency, because these people do not take adequate amount of food and basically thiamine. Good. So that's nice. It's nice. I'm going a bit slow. I'm mindful about it. Please bear with me. Yes, this is a wonderful question. My God, this is an awesome question. What is the therapeutic dose of lithium in acute mania? Therapeutic dose of lithium in acute mania is, yes. Any doubts on this? Any doubts on this? See, you should know about some points. I'll just say, because like these are all one-liners. If you know, you are cracking it. If you don't know, you're missing it. So please, there's no doubt. You need not look into this choice. You should have a wonderful mirror where you will search only as 0.8, 1.2, 0.8, 1.2. Now, what are the things that you should know about lithium? Lithium was a drug. It's a wonder drug which was introduced by a person called as John F. Cade. Who introduced lithium? A person who's 65, 70 years old, psychiatrist who loves lithium will give this question. John F. Cade. Okay. What is a drug which has a narrow therapeutic index? Yes, very obviously lithium. Narrow therapeutic index. Yes, very good. Next, what is the drug? What is a mood stabilizer which has? What is a mood stabilizer which is liver friendly? Is a friend to liver. Why? He's least bothered about what happens in the liver, but this person goes via kidney. Okay, kidney elimination. So any problem in the kidney will have a problem in the how it is eliminated. Now these are the 4 main points. I always tell my people, like, first you should know, before knowing about the side effects or toxicity and whatever it is, first you should know John F. Cade, narrow therapeutic index, liver friendly, kidney excretion. Sir, what is this narrow therapeutic index? Please tell me the range, sir. Now only we finished 0.8 to 1.2 milliequivalents per liter. I'll just introduce one small concept. There is another, this is for acute mania. Okay, now the acute mania is over, you're happy with the patient. Now we want to make sure that this person doesn't get the illness again. It's called as prevention, right? Disease prevention. It's called as prophylaxis. Now we have something called as 0.6 to 0.8 milliequivalents per liter. So this is for prophylaxis. This is what the standard textbooks say. Don't say that, sir, it was 0.7 somewhere, sir, I read in this material, sir, that material. Standard textbook says 0.6 to 0.8 is for prophylaxis, 0.8 to 1.2 is milliequivalents. And a brilliant person will be able to answer what is the range of lithium for both acute and also prophylaxis. It means what? You need to just add together and just give an answer from 0.6 to 1.2. Yes, it's just common sense. That's not rocket science. Yes. So please concentrate. 0.6 to 0.8 is prophylaxis, 0.8 to 1.2 is for acute treatment of mania. Yes. Yes, friends. Now, wow, this is again one-liners. I just want you to concentrate here All of the following statements are true regarding bipolar disorders except, okay, this is another headache. Okay, INICET is a headache, and this true except none of the above, which of the following except false, okay, not false, not true, all this is an added headache, so please be ready for that. Now they are saying what is the true regarding except, so which of the following is false. Okay, bipolar 1 has equal prevalence in males and females. I'm not sure, sir, leave it. 15% of the suicide completion rates, you should be having an idea of this. See, like mood disorders or disorders where the people have more chance of suicide, so 10 to 15%, yes, so it's satisfying it. So this is, you are ruling out B choice. Most common age group between 35 to 45 years. Wonderful, that's all, you are able to answer it. This is the answer. Sir, why, sir? It's because basically what are they saying? Bipolar disorders. What do you mean by bipolar disorders? What do you mean by bipolar disorders? See, a person has only depression in his lifetime. Okay, it is called as unipolar. Yes, it is called as unipolar. Very simple, sir. A person has both mania and depression in the lifetime. What is it called as? It's called as what? Bipolar. Yes, very specific. Now we should know only one common sense and like one point fact-based question is unipolar disorders, like unipolar depression, occurs around the age of 30 to 40. Okay, yes, 30 to 40, middle age basically. Bipolar occurs in a very young age group around the age of 20. Okay, yes. Now if you have this knowledge, this fact, okay, basically this is a fact. Until you step into psychiatry or read this point, you can't answer this question. You just know this fact. It's a very important fact. You will be able to answer this. More common in the age group of 35 45 years. No, definitely not 20 years. Prevalence is 1 to 2%. Yes, definitely the prevalence is 1 to 2%. This is accepted. This is definitely no. Bipolar 1 has equal prevalence. Yes, this is one additional point that you know. Male and females has the equal prevalence, but the age for onset is very, very important. That is 20 years. Unipolar has 30 to 40, whereas bipolar has 20 years. So with this idea, we'll step into the next point. Yes. Wow. They are making our time very easy. Okay. A 40 years old male with a history of alcohol intake for many years developed liver cirrhosis. His liver profile shows GGT, AST, ALT. Don't even, sir, I don't know about AST, sir. I don't know whether the normal level is 2, 3, 4, 40, 100. Nothing. You need not know that. Liver cirrhosis. That's it. Liver is deranged. Paka. You don't read that. Now we have stopped alcohol. Which of the following is most suitable drug to give to him to avoid withdrawal symptoms? So they are asking detoxification, liver derangement. Search for the choice. Lorazepam. As simple as that. As simple as that. Please concentrate. Deranged LFT is lorazepam. Normal LFT is chlordiazepoxide. Wow. This is another simple question. Okay. Eye movements of sleep stages was recorded by performing in a polysomnography. Which sleep stage that given part of the graph represents? Okay. Now what happened was that actually this is what it's all a recall question, right? So what we had is we had our students to say that the question was something like this. The image was something like this. Okay. Just if you look into the image, it will be like this. Now what happens that you have to be just shrewd enough to see if they are giving an image like this. EOG. Okay, EOG means what? Electrooculogram. Oculogram means what? Movement of the eye. Extraocular muscles. Now when the EOG, extraocular muscles are active, okay, so what should be the sleep? There are only two sleeps. Yes, there are only two sleeps. One is non-rapid eye movement sleep, another is rapid eye movement sleep. Yes, yes. Non-rapid eye movement sleep starts at the initial stages of sleep. Yes. Rapid eye movement sleep occurs in the late stages of sleep. That is the first point that you should know. Yes, I know, sir. Next, dreams occur in. Dreams, where do dreams occur? REM sleep. Dreams might occur, but it is not as in a consolidated story form in non-REM sleep. So till for exam sake, please remember, dreams occur only in REM sleep. Okay. Next, you have something called as very, very important. Muscle tone will be present. Muscle tone will be present in non-REM sleep. atonia will be present in REM sleep, except 3 group of muscles. What are the 3 group of muscles that will be active during REM sleep? Definitely your respiratory muscles should be active, otherwise it will die, right? The respiratory muscles, then rapid eye movement sleep, extraocular muscles, and very importantly, penile muscles. Yes, penile muscles. Everything is a one word. Everything is a one word. Extraocular muscles. Now, for answering this question, you need to just know that EOG, extraocular muscles, is active. So basically, I am able to say that this is nothing but a REM sleep. So the answer here is REM. Okay, I feel that you need not be an EEG specialist. Okay, not even neurology, DMPGs answer this question by seeing a EEG. You just need common sense. They are saying eye movements of the sleep is recorded, and they have put some like mark here. Now you have to just zoom in and see. For example, see here, in all other stages, it's flat. What, yeah, it's flat. Only in this stage there is something active, and they are asking only this. It's common sense. To be frank, it's common sense. It's rapid eye movements. Yes. Now, next question. Okay, one patient diagnosed with schizophrenia and started on risperidone. Now suddenly rushed to the emergency department with uprolling of eyeballs. What do you call it as, or what is the management of choice? Tell me what is it called as, and what is the management of it? Very important. Very simple to know. The answer is promethazine. Okay, why, sir? What is this, sir? If you are not sure of it, I'll just give you a small thing. See, antipsychotics. Yes, antipsychotics are basically dopamine blockers. If it is typical antipsychotic, it is dopamine antagonist or dopamine blockers. If it is the atypical antipsychotic, it will be SD, a certain dopamine antagonist. That's a different issue. Now we'll go to typical antipsychotics. This typical antipsychotics has a notorious motor side effects, and one such side effect is called as dystonia. One such side effect is something called as dystonia. Yes, dystonia. What do you mean by this dystonia? The tone of the muscle is like taut. Okay, basically what happens is it acts in the muscle, in the neck. Yeah, antropolis. Yes, it acts in the neck. Sometimes it happens in the eye. Okay, muscles of the eye, where you will have what is called as oculogyric crisis. So what are they saying is, I've seen family members coming and saying that, sir, so after giving the tablet, suddenly he's looking only up, sir. I just ask him, why are you looking up? Sir, I don't know, my eye is moving up. That is nothing but oculogyric crisis. Yes. Now for that, what is the treatment of choice? You should be very much sure that if you predict that this person is going to oculogyric crisis, prophylactically, you will be choosing one drug that is called as THP. What is THP? Trihexyphenidyl. Also called as Pacitin. Now there is another drug. This is for prophylactic, but for management reasons, you should have some other drug which is called as promethazine injection or diphenhydramine. Please search if a person comes with a crisis, okay, which is nothing but it's like an emergency in psychiatry. Please search for the choice of promethazine or diphenhydramine. If the person says that the person is having oculogyric crisis, now we don't want to get it again, or you want to prevent it. So by what you will give? You give it as trihexyphenidyl, also called as Pacitin. Okay, so basically they want you to know that, okay, a person is having an antipsychotic. There are some antipsychotic related motor effects. One or such motor related side effect is called as dystonia. For that, you know promethazine. This is called as like extra expectation of the examiners, but still I think you are worth it. That's why they're expecting. So please concentrate. There is something called as when you start the antipsychotic, there are multiple effects. One such effect is dystonia. The dystonia can affect the neck muscles, which you call it as antropolis or retropolis. When it affects your eyeballs muscles, it is called as oculogyric crisis. What is the emergency treatment? Search for promethazine or diphenhydramine. If you want to prevent it, go for Pacitin or trihexyphenidyl. Wonderful. You're really brilliant. This is a wonderful question. A 29-year-old lady came to the psychiatry OPD with symptoms of predominant depression. There is a history of past episode of mania. Now she's planning to conceive. Which drug should be given? This is a pharmacology question. This is a psychopharmacology question. This is a mood disorder question. And like, what are the keywords that I want to search is 29-year-old lady came with a psychiatric OPD with symptoms of depression, predominant depression. That's one keyword. That's one keyword. And there is a history of past episode of mania. What does it mean? What does it mean? The person is having many depressive episodes and there is one episode of mania. So it is bipolar or unipolar? Is it bipolar or unipolar? It's bipolar, definitely. So you are going for a mood stabilizer. Now among that, there is another clue that she's planning to conceive. She's planning to conceive. That's very simple. Then you should have some idea about teratogenicity of the mood stabilizers. Okay, I'll just introduce. The answer is, anybody can tell me? Yes, you're brilliant. Answer is nothing but lamotrigine. That is a drug that you should get. Why, sir? Why are you showing partiality towards lamotrigine? It's because there are some questions that has been asked. Okay, so please concentrate here. Please concentrate here. A person has predominant mania. A person is having predominant mania. Okay, or bipolar mania. Okay, out of his some 5 to 6 episodes, there is 4 episodes of mania. There is only one depression. Predominant mania. What is the treatment of choice? If they ask a question like that, go for answer of lithium. Go for lithium. A person is having predominant, there's only one mania episode, but the person is having predominant depression. Predominant depression. What I should choose? You go for a drug called as lamotrigine. Yes, yes. A person from January to December, as 1, 2, 3, 4 or more within 12 months. What do you call it as? What is the drug of choice? Valproate. Yes, yes. Now the another point I told you is, see, among all the mood stabilizers, the drug which is safe in pregnancy is again, it is nothing but lamotrigine. It's nothing but lamotrigine. Why, sir? Because when you take the mood stabilizers per se, lithium, what is the problem with pregnancy? In pregnant women, what they will have? They will have what is called as Epstein's anomaly. Yes, most repeated question. Valproate. I think everybody knows. Valproate, what is the side effect for the baby fetus? They will have neural tube defects. What is the drug with? What happens with carbamazepine? Carbamazepine, I'm still very hesitant to use because it can cause cleft lip, cleft palate. But when it comes to lamotrigine, it's pregnancy safe. Yes. If you know all these points, that predominantly mania means it is lithium. Predominantly depression means it is lamotrigine. Lamotrigine is safe in pregnancy. Rapid cycling is valproate. Lamotrigine has no that much serious teratogenic side effects. If you have this 5 to 6 points of the mood stabilizers, I think you need not worry about the question at all. Predominant depression, yes, I am towards lamotrigine. One episode of mania, yes, but I am very much sure. And if the person is planning to conceive, definitely the answer should be lamotrigine. Wonderful. Which is exclusively seen in females. Anybody can tell me? Yes. Now this answer is, please concentrate. Now we should just look into that. The questions are saying that it's all about autism, selective mutism, Asperger's and Rett's. So basically you should have an idea that this is from a disorder called as autism spectrum disorder. Now you should know what are the characteristic features of autism, and one extra point, if you have known, you will be able to answer this. Please concentrate. I would like to just say about this point. What is it called as autism? Autism is a triad. What are the 3 triad of autism? The person will have verbal and non-verbal communication deficits. The person has verbal and non-verbal communication deficits. Yes, very good, sir. Yes, I can get it, sir. Next, the person has a problem with social interaction. He always likes to be alone, right? So social interaction. Next, the person will have something called as RRBI, restricted range of behavior and interest. Okay, please look into it when examiners ask it. Okay, because like the day for autism awareness is on April. So the thing is that the exam is nearly coming around just 1 month after that. So examiners might be very fond of it. So please be aware of it. Verbal and non-verbal communication deficits, social interaction, and RRBA, restricted range of behavior interest. There will be a very lengthy question. A 2.5 years old child who's having not communicating well with the family members, not communicating well with others, that doesn't like to play with others, plays with only a solitary play. The patient doesn't have an emotional connection with others, doesn't have an eye-to-eye contact, doesn't turn when the child is called for. There'll be like totally like big paragraph, lengthy paragraph, as if a PG is presenting an exam case. But if you have this triad means autism or autism spectrum disorders, it's going to be a child's play. Now this is what you should know. Now added point for RETS is along with this triad, what is the triad? Repeat with me. This is how if you are on face to face, I will make you repeat 10 times. Verbal and non-verbal communication, social interaction problems, and RRBA problems. All the three is there. Yes. Along with it, RETS is the disorder which is common in female child. Okay. There is a problem with MECP2 mutations. And very importantly, what you should know is this. There are some other problems with this. One is called as they have seizures, they have scoliosis, they have irregular respiration, and very importantly ataxia. Yes. So RETS is nothing but there is a triad of autism. What are the triad? Decreased verbal and non-verbal communication, decreased social interaction, RRBA. Now what are the components of RETS? They have seizures, they have scoliosis, breathing irregularities, and ataxia. Now we'll go to the wow, this is a wonderful question. Yes. What is the true statement for OCD? Okay. What you should know about this is this is a very practical point. Okay, if you have many of you are preparing for exams will have OCD, because I'm a person who's like I had OCD before my exam, like before like 10 days or 15 days, that crucial time of preparation, I'll get OCD. After that exam is over, I'll be fine. Okay, that is how it is. Now what happens is that whenever you're too much stressed, whenever you are getting too much emotion, or when you're too much pressurized, naturally it is associated with OCD. So the first point is commonly associated with depression is excellent. That's a wonderful point. Now atypical antipsychotic is the first line of treatment. No, never. Please concentrate. Let's look into the other choices. Atypical antipsychotic, no. You know that what is the treatment of choice? It is the SSRIs in large doses. Prevalence is 7 to 10%. No, not that much severe. We have around 2 to 3%. Yes. Contamination is uncommon obsession. See, this is wrong because it is the most commonest obsession. Okay, so you are able to answer it. I'll just introduce some facts about OCD. You know this. The most repeated JIPMER. Okay, previously JIPMER was a separate paper. Now it is all clubbed into INICET. JIPMER question is neuroanatomy of OCD. O and C. What is it? Orbitofrontal cortex. There's something called as cingulate and caudate. Next, we have something called as neurochemistry of OCD, or the neurotransmitter of OCD. Everybody knows this answer. Serotonin. Yes, one-liners. You know, you get a mark. You don't know, you lose it. Very good. Next, what is the neuroimmunology? Neuroimmunology is nothing but pandas. What is pandas? What do you mean by pandas? Everybody knows this. Pediatric, autoimmune, neuropsychiatric disorders associated with Streptococcus. Why is this very important? Because this is asked in neurology, medicine, pediatrics, microbiology, psychiatry. Yes, so you should know about pandas. Pediatric autoimmune neuropsychiatric disorders with Streptococcus, nothing but it's autoimmune, definitely. So basically what happens, the antibody is going to affect your own body. So what happens, it's going to affect and cause what? It can cause tics and OCD. It can cause tics and OCD. So that is one thing that you should know. So neuroanatomy is there, neurochemistry is there, neuroimmunology is there, and anything else that you want to just look into. Very importantly, comorbidity. Comorbidity, it is associated with depression. And I just want to introduce you one extra point. What is the most common obsession? What is the most common compulsion? Both is C. Okay, both is C. Everybody after this COVID, we are at this right? We keep on watching. Contamination. What is the most common compulsion? Checking. C and C. Please concentrate. C and C. So I want you to just be here. Okay. There will be also questions that is asked in like obsessive compulsive related disorders. I'll just put those words also in the subsequent slides. But as of now, you should know that neuroanatomy is OC, orthoprefrontal cortex, caudate, and cingulate. Whenever I repeat a point, please don't feel that okay, I'm just taking your time. Please repeat with me. Okay. Neurochemistry is nothing but serotonin. Neuroimmunology is pandas. What is pandas? Pediatric autoimmune neuropsychiatric disorders associated with Streptococcus. Streptococcus is there. Antibodies there. Antibody rather than affecting Streptococcus, it goes and affect your own body. So what, sir? It will result in tics and OCD. What is the comorbidity? Depression. Most common obsession? Contamination. Most common compulsion? Checking. Very good. Very good. Now, I'll just add 2 points here. Okay. What is the non-pharmacological treatment? So I told you pharmacological treatment is SSRIs. Okay. Non-pharmacological treatment, you can't afford to make a mistake. ERPT. What is ERPT? What is ERPT? Exposure and response prevention therapy. Yes. Now there is in DSM-5, there is something called as obsessive compulsive related disorders. It means that they are just clubbing into certain disorders from other classifications. DSM-5, as we have for DSM-5 and ICD-11, what is the problem is that we have some classification. We'll just rearrange things for a better understanding and better like diagnosis and treatment. But still for students, it would be like an added pressure. But still, I think you will be able to manage it. One thing is that other than OCDs, what all will be handled? There is something called as hoarding disorder. What do you mean by hoarding disorder? You just collect things, okay, you don't get rid of things. That is hoarding disorder. We have something called as hypochondriasis. Okay, hypochondriasis. We have something called as body dysmorphic disorders. Body dysmorphic disorders. They feel that my hair is not right, my skin color is not right, and very importantly, they have something called as trichotillomania. What do you mean by trichotillomania? Trichotillomania means hair picking. You just pick the hair, you throw it down, or you eat it. Phagia, trichophagia, or it causes obstruction, trichobazar. That's all surgery questions for trichotillomania. And very importantly, we have something called as skin picking disorder. Skin picking disorder. If you have read this before, it's good. If you are reading it for the first time, please just spend some time over it. Okay, it's because these disorders, though it was classified, see for example, this hypochondriasis, body dysmorphic, and all for different anxiety disorders. Trichotillomania was something like impulse control disorders. Now what happened was they want to just put it into one class so that it has some quality of that irresistible desire or this irresistible like repetitive behaviors that as it's seen in obsession. So it's for again, it's a very important for exam point of view. Hoarding, hypochondriasis, body dysmorphic disorder, then you have skin picking disorder or trichotillomania. Okay, what is the non-pharmacological treatment? Non-pharmacological treatment is ERPT. What is pharmacological treatment? SSRIs. Most common compulsion is checking. Most common obsession is contamination. Comorbidity is depression. And what is PANDAS? Pediatric autoimmune neuropsychiatric disorders associated with Streptococcus. Now this is a wonderful question. Which of the following statements is true about Korsakoff syndrome or Korsakoff psychosis? See, one thing that you should know is, I just say this point, when a person doesn't eat properly, he will have what is called as thiamine or B1 deficiency. Now what happens is that this is the question that has asked been Wernicke's encephalopathy is a question that is asked in NEET. Okay, so you can expect Korsakoff's in INICET. So what is Korsakoff psychosis? Wernicke's encephalopathy is a triad of, I find everybody having only one clue, that is Goa, right? Because everybody has plans. Okay, Goa. What is G? Global confusion, ophthalmoplegia, ataxia. Very simple. Try it. Close your eyes. If there is a question on ophthalmoplegia, ataxia, and a person is having global confusion, the person is taking chronic alcohol, not taking regular foods, search for Wernicke's encephalopathy. Wernicke's encephalopathy. Why, sir? Treatment is IV thiamine, 100% reversible. 100% it's reversible with thiamine. Now, what is Korsakoff psychosis? Korsakoff psychosis is nothing but the person will have, please concentrate, the words that you should know is anterograde amnesia. That's first thing that you should know. Then we have something called as confabulation. Yes. Next we have something called as filling up of memory gaps. What is this? Is that, see, after the class I asked you like what did you do? If you are in a live session, I asked you like what we're doing at 8:20. You would say, sir, I was discussing some third or fourth question you were discussing and I was answering. I was trying to answer, sir. Now what happens is that I am a person with Korsakoff psychosis. Now I am a person who takes alcohol. I'm not taking regular food, so thiamine deficient, B1 deficiency, so I have got Korsakoff psychosis. What did you do at 8:20? If you ask the question, I don't remember, no, like I can't recall, like, because I have like amnesia. So what I will do is I'm not able to form memories. I will say that normally what I used to do in 8:20 in the evening, I used to be in my clinic seeing patients. Yes, so I was seeing patients. I able to feel that is called as confabulation or filling up of memory gaps. So there is another thing called, there is another the wonderful point, anterograde amnesia, loss of retention memory, and very importantly they will also ask one question called as confabulation, that is filling up of memory gaps. Yes, yes. Treatment of choice for Wernicke's encephalopathy IV thiamine. Why they ask this question is because if you just diagnose it, treat it, 100% reversible. Yes, wonderful. This is another type of question where it's again one liner. Okay, you can't just make a wild guess. Which of the following is a novel antidepressant? Okay, now you know one thing that you can say is lorazepam. I think you can rule out. Lorazepam is a mood stabilizer. So if you are very aware of some drugs, okay, one particular drug that I always say is, see, everybody knows SSRI, everybody knows what is SNRI. So you should have an idea about some other drugs. Okay, one thing is that you should know what is called as a SARI, SPARI. Okay, what is this? Is serotonin antagonist and reuptake inhibitor. SPARI is serotonin partial agonist and reuptake inhibitor. I don't want to go deep into it. Just know the name of the drugs. They are something new which people might ask. SARI is nothing but the drug is trazodone, nefazodone. Trazodone, what happened? Trazodone, what happened was it didn't hit the market because of a problem called as priapism. And nefazodone was a problem because it had liver toxicity. What is SPARI? SPARI is nothing but we have something called as vilazodone. Okay, what do you mean by that? It will have both the partial agonist and SSRI like inhibition, where it is used for both treatment of anxiety and depression. We call it as MAD disorder. What do you mean by MAD disorders? You can use it for mixed anxiety depression. You can use it for mixed anxiety depression. Okay, so if you just have this idea, because SARI and SPARI you can't afford to miss. See, there are 100 amount of new drugs, like 4 or 5 drugs you can know. Like we have something called as agomelatine, or we have something called as newer drugs we get, no, like esketamine. So these drugs are something new. Okay, FDA keeps on approving some 4 or 5 drugs, which you if you have an idea extra hold, it's good. But I basically feel that this examiner is not that much a sadist, because vilazodone is a drug which has been here for many years. So SPARI is trazodone, nefazodone. SPARI is vilazodone. So answer is novel is vilazodone. Yes, novel antidepressant. Wonderful. These are the 2 things that you should know. Most efficacious drug in smoking cessation is, whenever there is some drug on smoking cessation and the question asks bupropion, go for bupropion. Go for bupropion. Why, sir? Because there are several words on this bupropion. Okay, I know that I'm taking some of your time. Please bear with me. Bupropion is a, okay, there are some 5 one words that is there. Bupropion comes under class of NDRI. What do you mean by NDRI? Noradrenaline dopamine reuptake inhibitor. Now this NDRI is used for smoking cessation. Now it's also called as Zyban. It's also called as Zyban. And very importantly, the problem with this drug is it will cause seizures at dose is increased. When the dose keeps on increasing, seizures. All this point is one word. Bupropion, NDRI, Zyban, smoking cessation, seizures. Wonderful. Now another point that you should know about this bupropion is, is there any other drug? Yes. If bupropion is not there, search for varenicillin. What is this, sir? Very complicated word. It's nothing but alpha 4 beta 2. Please concentrate. Alpha 4 beta 2 partial agonist. Okay. So I want you to concentrate this slide. Bupropion, NDRI, Zyban, smoking cessation, seizures. These 5 words should be there. Forget everything about bupropion. Don't know anything. If you don't know anything about bupropion, it's fine. These 5 words: NDRI, Zyban, smoking cessation, seizures. Bupropion. Varenicillin is alpha 4 beta 2 partial agonist. Wow. Now this is again like it's whenever you see these questions, you get panic. I also get panic. So only thing is that you should know some. This is all like if you read some newspaper or Facebook or some decent articles, you will be able to answer this question. That much simple is this. Now suicide. Okay, what do you mean by suicide? First of all, we'll see about overworking. Now you are all overworking, right? Now what is that? Feeling that goes away as soon as you leave the hospital. Very good. Yes, you are all experienced this. You have all experienced this. So 4 is this. Yes, feeling that goes away as soon as you leave the hospital. Yes. What is burnout? Burnout is like where you experience it when you are in a tertiary care center where you see terminal cancer illness patients. Most of these people, you know, the people who go into this like what is it, onco surgery, or they finish MBBS, they finish MD, they get DM oncology, or they do MCH onco surgery. Now what happens is that after doing all this, they go and stand there and they see people just literally like bones, or they literally like they drop like they lose their life in front of them. The thing is that you're not able to accept. See, I'm a doctor. If a patient comes to me which I'm not able to treat, a psychiatric patient, I feel very challenging, right? Now these people are feeling that, okay, am I doing anything worthy, or am I doing anything perfect? So what happens is that it's the exhaustion that happens. That is most common seen in tertiary care centers where you see only severe cases. Exhaustion is a word. So emotional and physical exhaustion caused by prolonged stress. That is also called as burnout. Now, depression. Where do you see depression? This is very, very important. Depression is difficult to diagnose due to shell of physician's pride. Okay, this is what we always say. Okay, whenever I go for like stress management program for schools or colleges, like wherever I go, there will be like there are after I do a program and I send a video of things, doctors used to ask like, I think you should do a video for doctors. What happens is that this will be useful for them because you also have depression. For example, you are a person who's you are a medico. People respect you. You have this doctor tag, right? DR, which is like they feel that you're something different. They expect too much, and you have that like false like ego and all that. Now, because of which, what happens is that you don't openly say that yes, I have a problem. I want help. I need to just talk with the person. You feel that talking to a psychiatrist is a stigma. Say asking help from some other person is a stigma. So this is another thing. And again, suicide is more common where where it's more common in, if a person is having relationship problems, yes, definitely. Substance use, yes. Women, yes, there is more prone for risk for suicide. So this is again, I don't think so that it's more of a core psychiatric question. It's a bit of a common sense question. So 1 goes to B, 2 goes to D, 3 goes to C, and 4 goes to A. The answer is this. Yes, very good. Now, before going to the other, these are all like common sense, but now we have some concepts. A person comes with severe depression with suicidal ideas. What is the treatment of choice? Severe depression with suicidal, what is the treatment of choice? Close your eyes, close your eyes. There should be no, see, you should need not go into the search for the choice and all. Okay, you should know the answer. What is the person who's having severe depression with suicidal ideas? It is ECT. What is ECT? Electro convulsive therapy. Are you sure about it? Yes. Now, after this ECT point is there, then you need to know, is there any drugs which will has anti-suicidal properties? Is there any drugs which has anti-suicidal properties? Okay, which are recent advances and it will be very much asked in research. So what you should know is anti-suicidal property is there are 3 drugs. One is lithium. Okay, I told you John F. Cade, narrow therapeutic index, liver friendly, kidney excretion, abstinence anomaly. This is anti-suicidal drug. Second, we have something called as clozapine, and third, we have something called as ketamine. Ketamine is again anesthesia. Guru will come and say that ketamine is a dissociative anesthetic. Ketamine is an anti-suicidal drug. Ketamine is also called a special K. It is an hallucinogen. But what you should know is it is anti-suicidal because most of the ketamine is a type of ketamine which is most commonly evidentially researched for severe depression with suicide. Yes, these are all recent advances. Is there any, what is the drug which has anti-suicidal property? If they ask the question, answer is lithium, clozapine, ketamine. But if a question is severe depression with suicide, what is the treatment of choice? Search for ECT. Repeat with me, ECT, electroconvulsive therapy. Yes, did I say the answer for this? Yes, good. Next. A person often feels that his hands are dirty and urge to wash his hands. Recently noticed that these repetitive and distressing thoughts of hands washing is affecting his performance. What is the best treatment option that is available? It's very simple. I told you already. Excellent. ERPT, exposure and response prevention therapy. The most important area where people ask questions is what is ERPT and what is EMDR? ERPT is exposure and response prevention therapy. EMDR is eye movement desensitization and reprocessing. What you should know is where do you use ERPT, where do you use EMDR? ERPT is used in OCD and EMDR is used in PTSD. Yes, you're all with me. Friends. That's very good. So answer is exposure and response prevention therapy. Please concentrate on this. ERPT is exposure response prevention therapy used for OCD. EMDR is eye movement desensitization reprocessing used for PTSD. What is PTSD? Post-traumatic stress disorder. Wow, this question which I have repeated before. Which of the following is not classified under OCRD, means obsessive compulsive related disorder, as per ICD-11? Okay, fine. Trichotillomania, yes, I told you somewhere. Hypochondriac, yes. Body dysmorphic disorder, yes. Post-traumatic stress disorder will not come. Yes, post-traumatic stress disorder will have a separate diagnosis on called as trauma and stress related disorders, so it doesn't come. As simple as that. What is the treatment of choice for PTSD? Very good. EMDR, eye movement desensitization reprocessing. Now, this is again very important question. A 40 years old male patient comes to psychiatry OPD with complaints of having repetitive thoughts that his hands are dirty. See, I told you, OCD is another area where examiners are very fond of. Thought, though they are not, you know that this is his own thoughts only. The thought was given him discomfort. He is suffering from disorder of. Okay. Now for this is like there are 2 things that I wanted to introduce. Please concentrate. Okay. A person has obsession. What are the qualities of obsession? Recurrent, irresistible, distressing, and very importantly, ego dystonic thoughts. Okay, ego dystonic thoughts. These words are very, 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 very important. The person has a recurrent thought. It is irresistible. Why he is not able to control it? So let the thought comes. Why is he bothered? It's very distressing. Why it is distressing? Because it doesn't match his personality. I'm a clean person, but the thought comes is my hand is dirty. I'm a person who loves kids, but the thought comes is that I should throw kids or kill kids. So it doesn't match my personality. And I know very well that this is my thought. Why this thought is coming? The thought did not come. I know that its own thought. I'm not able to control it. So these are the qualities of obsession. The examiners again is an examiner who is a very, very, very kind-hearted person, where complaints of repetitive thoughts, hands are dirty, that is contamination. Okay, no, this is one thoughts only. It's discomforting, so it is nothing but obsession. Now they are asking it a different indirect way. Obsession is a disorder of thought. What? Okay. Okay. There need not be any doubt in it. There will be any doubt in it. Thought, under thought disorders, there is one words that you should know: disorder of thought possession, disorder of thought content. The disorder of thought possession is obsession. Disorder of thought content is delusion. Yes. Now, please, there is a, you can ask, sir, I read this where I read a new article here, sir. Reason PubMed says this, sir. Nothing going. When it comes to psychopathology, it is either sims or fish. And we all psychiatrists all over India who are on the teaching side is going to accept this. Disorder of thought possession is obsession. Disorder of thought content is delusion. There is no doubt it. Ego dystonic means obsession. Recurrent, irrelevant, intrusive ego dystonic thought is obsession, and the patient knows its own thought. So this you can't afford to make a mistake. No confusion. Yes. No second opinion. Thought obsession. Obsession means thought possession. Content means it's a disorder of thought content is delusion. Which of the following are subtypes of subcortical dementia? Okay, except. Okay, again this except is nothing but false. Okay, now what happens is that again you should have some good idea about dementias. Now what are they expect you to know is Huntington's disease is what? Huntington's disease is it's a type of dementia where it's a subcortical. It's a subcortical structure, basal ganglia. Wilson's again subcortical, basal ganglia structure. Parkinson's again, Parkinson's is a basal ganglia. Fixes is nothing but frontotemporal, where it is like both all the lobes is involved. So it's called as it's a cortical dementia. So subcortical dementia except is nothing but cortical dementia. One thing that I would like to say is most expected cortical dementias and subcortical dementias. Cortical is nothing but Alzheimer's and PICS. PICS also called as frontotemporal. What you should know about subcortical, most important structures is Huntington's, Wilson's, dementia with Parkinson's disease. Okay, this should be in your memory. Yes, if you know this classification, again this is again medicine question, psychiatry question, neurology question, and dementia again I think we have read it many times in pathology. So this is one thing. Now another thing is that reversible and irreversible dementias. Reversible and irreversible dementias. This is again area of question where people will be asked questions. What are the reversible dementias? Anybody? You should be very much careful in this. Please concentrate. Reversible dementias is nothing but vitamin B1 deficiency, vitamin B12 deficiency, niacin deficiency. Next, they have something called as hypothyroidism. Hypothyroidism will present as dementia like symptoms. And very, very importantly, we have something called as NPH. What is NPH? Normal pressure hydrocephalus. What is the triad of normal pressure hydrocephalus? It is a triad. We are dealing it about dementia, right? So dementia. The person will not be able to walk, ataxia. And very importantly, they will have what is called as urinary incontinence. They have something called as urinary incontinence. Yes, NPH. Okay, this is again a medicine question. So vitamin B1, B12, niacin deficiency, hypothyroidism, and normal pressure hydrocephalus. What is the difference between cortical and subcortical? Cortical is Alzheimer's and PICS, frontotemporal dementia. Subcortical is Huntington's, Wilson's, and Parkinson's. Very good. Wonderful. This is a question that the examiners are very much fond of asking. I know. I think you will be able to answer this. All of the following are good prognostic factors in schizophrenia, except. Okay. I think everybody is aware of this type of question. First of all, you should know that positive symptom is a good prognosis. Yes. So this is a good prognosis. Right, that's good. Late age of onset, yes, good prognosis. Associated with depression is a good prognosis. Insidious onset of symptoms is insidious means slowly. Like this is 2023. The person has symptoms slowly developed, like for past 3 years, slowly symptoms started. Sir, it's a bad prognosis. So this is the answer. Yes. Now I'll just tell you this table, or like what to say, you should be in your memory. Like I ask a question, you just tell it by hearted. Okay, there's nothing like you're reading it new. Best, better, good, bad, worst. What is the schizophrenia which are best prognosis? Catatonia. What is which one is a better prognosis? Paranoid. What is the schizophrenia which has good prognosis? Undifferentiated. You're not able to classify it as one. Undifferentiated. What is the schizophrenia which has bad prognosis? Epiphrenia, also called as disorganized. And very importantly, worst schizophrenia has nothing but simple schizophrenia which has a worst prognosis. Please picturize this in your memory. I think you are very much aware of it. Best is catatonia. Better, paranoid. Good, undifferentiated. Bad, epiphrenic, also called as disorganized. And very importantly, worst is simple. And regarding the prognostic factors, good prognostic factors will be female gender, yes. Late age of onset, around 40, yes, it's a good prognosis. With stressor, there is a stressor, the person has psychosis or schizophrenia. Once he resolves the stressor, some amount of medications, patient will be fine. Stressors, which is abrupt onset. After the stressor, suddenly he has symptoms, abrupt or acute onset of symptoms. What is the schizophrenia which is the best prognosis? I told you, catatonia or paranoid. Next, which part of the world this person is living? He's living in something called as developing country like India, Sri Lanka. Okay, they have good prognostic factors. Next, very importantly, you start antipsychotic and they are regular to medications. That is good prognosis. There is a good response to antipsychotics. There is a good response to antipsychotics. Again, that's a good prognosis. And very importantly, what is very important thing that you should know is this person have DUP. What is DUP? Duration of untreated psychosis is less. What do you know by this? Duration of untreated psychosis is less means this is March 2023, right? Now the person had symptoms like March 1st, and like they are bringing it in the last within 4 weeks. That's like reasonably well. They try, they all do all prayers, nothing works, then they bring. There are people who bring illness after some 6 years, 5 years, 4 years, they don't take good treatment at all. There the prognosis will be bad. So just concentrate. Female, late age of onset with stressors, which has an acute onset. There is catatonia and paranoid symptoms. Developing country, developing part of the world, regular to medications, good response to antipsychotics, and DUP is less, will have good prognosis. Best, repeat with me, best, catatonia. Better, very good. What is it? Paranoid. Good, undifferentiated. Bad, it's either epiphrenic or disorganized. And worst is simple schizophrenia. This is again a small wonderful point. Okay. A male patient who lost his job recently became irritable and had a sad mood most of the time. Thinking about the future gave him worries and he felt irritated towards his family members. He occasionally went to watch movies with his friends and was able to enjoy it, but on returning home he felt similar symptoms. What is the diagnosis? Is it depression? Is it anxiety disorder? Is it adjustment disorder? It's mixed anxiety depression. Now it's very simple, right? It's like there are 3 questions that has been asked. I'll just try to summarize, okay, with this question. A male patient who lost his job. Okay, now what happens is that you need to just concentrate on one point. See, I'm a very productive, positive person. Now I am a person who's diagnosed with my son is diagnosed with a cancer. Now I'm really feeling very bad, sad, and very much worried. Now once I go out of the environment, I go to my work. I start doing my work regularly. I'm just very active. I relate with people. But once I come back to my home, I see my son. I'm feeling very much sad for the person. But I don't stop there. I go see all possible doctors that is on the list. I take treatment. I make sure that he's fine. That I'm hopeful that things will get better. This is what is called as adjustment disorder, because it's not depression. In depression, they will have pervasive, persistent low mood. Wherever he goes, in house, in work, with friends, with family, with son, with wife, with daughter, wherever he goes, he will have depressive symptoms. But here the person is having, only in house he is dull, but in workplace he is fine. So that is characteristic feature of adjustment disorder. Okay, there are 3 questions that is asked. Okay, I openly tell it, there will be very big questions. A father diagnosed of cancer in a son, work is fine, home he returns, he's sad. Another thing is this fellow. This fellow is the lost his job, right? This fellow is very much worried, sad, depressed, and all that. But still, when he goes to movies, he's enjoying time, he's having a nice meal. But when he comes back home, he's very much sad, he's very much distressed, he's very much panicking because he's thinking about the loss of job, financial instability. There's another thing is that love failure, where a person after love failure is very much sad, misses the girlfriend, but when his friends come, ask him to come for a party or go to a movie, he goes and shares good time with his friends, memorable moments. But when he again comes back home within 4 walls, he's a bit sad or worried. Okay, friends. Okay, yes. Now these are the things that you should know about adjustment disorder. Okay, adjustment disorder is where you tend to have a problem with the situation. For example, you all have adjustment disorder. We all have adjustment disorder. Now, you see a movie, you see some trailer, you see something fine, you're happy. You call a friend and talk something, some gossip, you're all fine. But when you sit in front of a class, you're all sad. Yes, this is adjustment disorder. So adjustment disorder is something in a life event, you have to face it, and you try to face it, you cope with it. In other space of life will be reasonably well, and that is adjustment disorder. Whereas depression is where the person will have pervasive, persistent low mood. There is a quality of depression. Yes, friends. So I've tried to just finish as much as possible. Okay, I thought like rather than just saying the question answer, I thought like if I add some contents regarding it, it would be useful for you, because it's like it's definitely it's worth it, because examiners trick, we should have some reading the mind of examiners, because if they ask a question on one particular topic, there is a few chance that they will ask on a different topic. There is a very good chance that some small subtype of that same disorder. For example, they have asked what is the most common obsession is contamination. Next time there will be most common compulsion, which is checking. Okay, this is pharmacology of OCDs, SSRI. Next time non-pharmacological of ERPT. Neuroanatomy for OCD is orbital pharmacocortex this time. Next time will be neurochemistry or neuroimmunology. So that's trick. So I thought like rather than just question and answer, I thought like I should be able to give you adequate amount of things. Definitely we'll meet soon, so we'll try to just get as possible recall questions as possible. So I think I have finished more than half of it, and I think it was definitely useful for you. If you think that I've been taking some extra time, just bear with me. It's mainly to just convert your short-term to long-term memory. So just continue repeating things, and I think things will be all fine. Yes, friends? Yes? Good. All the best, friends. Thank you. Take care. Have a good day.